There we go.
Yes.
So it's my privilege to talk with you today about unruptured cerebral aneurysm, taking more of an evidence-based approach as far as determining what their natural history is and our treatment options. I have no disclosures. So we'll go with our first case example, and this is pretty typical of what you would see in an outpatient setting in the clinic. We have a 67-year-old gentleman, history of hypertension and cigarette use, who was found to have incidental aneurysm. His past medical history is otherwise non-contributory, as well as a social history, except for what we've mentioned above. He does have a family history of ruptured aneurysm, a first degree and a second degree relation with cerebral aneurysm hemorrhage, otherwise non-focal. Here, these are some CT angiograms. It's a little difficult to see, but we'll get a little bit better pictures on the angiograms. You can see this large kind of kidney bean-shaped posterior communicating artery aneurysm. It measured about 8 by 6 millimeters in size. And on the reconstructions, you get a better idea of what that aneurysm looks like, the posterior communicating artery coming off of the base, but also with this smaller ICA terminus aneurysm. So when you're presented with these multiple aneurysms in this patient, what would you recommend? Generally speaking, these are the choices that you have. You can observe these incidental aneurysms. The patient does not have a history of a prior subarachnoid hemorrhage. You can either treat both aneurysms, the posterior communicating artery aneurysms, or treat one or the other. For this instance, Dr. Fox, any comments you'd like to make about this so far?
Yeah, this is an interesting case and something you'll see very frequently in practice with one aneurysm that is perhaps a little easier to make a treatment recommendation on, and a secondary aneurysm that may not be quite so clear. I think most people who are presented with a patient who has a family history of ruptured aneurysms and a relatively large posterior communicating aneurysm would recommend treatment for that, regardless of method, either microsurgical quick obliteration or vascular treatment. More sort of nuanced discussion here is probably what to do with that ICA terminus aneurysm and how that would affect your overall management in this patient for both aneurysms.
Absolutely. That is kind of the discussion that you have with the patient. I think a lot of us would be in agreement that the posterior communicating artery aneurysm, especially since it's somewhat irregular with that kidney bean appearance and its size, would lean toward offering some type of treatment. And the treatment options are varied and really depends on what your practice patterns are and how you see things. The ICA terminus aneurysm, those are small. Those are that one was small, and obviously an incidental finding. And depending on what your philosophy is, you can either choose to observe that or proceed with treatment, especially if you're able to treat both in one setting. And depending on the individual practitioner, there can be quite a bit of variation in what to do with these aneurysms. But as we're all aware, aneurysms are abnormal focal dilation of the artery resulting from the leaking. The prevalence of around 5% in the population, depending on the type of study. The rupture risk is where a lot of the controversy, and that is what we're going to spend a lot of our talk today on.
So, just getting back to that first case presentation, what did you decide to do with that patient?
So I ended up proceeding with coil embolization of the posterior communicating artery aneurysm and elected to observe the ICA terminus. And again, in these instances, you do have kind of a coordinated discussion with the patient in terms of what risks that they're comfortable with. Even with the family history, he wasn't particularly inclined to proceed with treatment of both. And I think that's reasonable, at least in my opinion, to follow the much smaller aneurysm. There's very saccular in nature. Although proceeding with treatment of that, I think, is also very valid.
Yeah, I think that's a very reasonable plan. And again, this is a great case because it highlights many of the issues we're faced with in practice. And one of the things that we all deal with is selection bias and seeing a similar aneurysm in the past and letting that guide you rather than thinking about a more holistic view of the aneurysms presented to you based on the literature. So in my experience, I can think very clearly of a recent patient who was young, in his mid-30s, who had headaches and had a very similar looking ICA terminus aneurysm that was about the same size that we elected to follow. And then it quickly expanded, and fortunately he didn't rupture, but we were able to treat that. But, you know, I think we all have these issues where we remember the last case, and that may guide our current treatment recommendations. So it's important to, you know, again, keep a broad view in mind and discuss all the options with patients as they present. I agree with you in your plan. I think I would have done the same thing. Will the PCOM aneurysm, if it looked like it was easily coiled at the time, maybe the ICA terminus aneurysm. But again, that's very dependent on the discussion with the patient.
No, absolutely. And also there's other factors as well, that, like the patient age difference between a 30-year-old and a 67-year-old. Unfortunately, in your instance, you guys were able to follow it and catch it before it ruptured.
Yes.
But, you know, so our understanding of the natural history of unruptured aneurysms is really based upon multiple landmark papers. And here's a list of the 4 that we'll discuss in a little bit more detail. So in this setting, what would you quote for the rupture risk of this posterior communicating artery aneurysm? And really, again, our understanding, as I said, based on previous literature, anywhere from less than 0.5% per year, 1.4% per year, 2.6% for 5 years, 14.5% for 5 years, or also, you know, who cares, ticking time bomb, all aneurysms. Looking at the landmark paper by Weavers et al., this was out of the Mayo Clinic, and this was published back in 1981. There were 65 patients with 81 aneurysms that they followed for 5 years. Majority were women, and just over half of them were symptomatic. What they found in this group was that 8 aneurysms ruptured over this 5-year time period. No aneurysms less than 10 millimeters ruptured. So 4 of the aneurysms were between 10 to 20 millimeters in size, and 4 were greater than 20 millimeters. Additionally, they found that if an aneurysm was less than 8 millimeters in size, it was unlikely to cause symptoms. Based on their findings, they recommended that all aneurysms over 10 millimeters should be treated urgently. This is the first paper looking at, or one of the first papers looking at the natural history of unruptured aneurysm. You know, again, with these types of studies, one of the most important things to look at is what is the ultimate patient population? What's the selection bias inherent in the study? You know, for one of the problems of follow-up of this over the last 5 years of their study was by communication, either in clinic visits or by telephone, and just to see how the patients did. Basically, they're seeing, are you developing a neurological symptom, or have you had a rupture since we last saw it? A lot of this, again, based upon the timing of the study and history, non-invasive imaging was not as prevalent for these types of lesions, so the only way to really follow them would be with a catheter.
Yeah, this is just to interject one thing here, and I think this is a very important study in the evolution of the treatment of unruptured aneurysms. And you have to remember that not too long before this paper was published, there were still series of patients being treated with carotid ligation for intracranial aneurysms. that was sort of through the 1960s, and it wasn't really until that period as well that Dr. Yassergill and others began to describe the microsurgical treatment of aneurysms. So really, through that period of time, unruptured aneurysms were not routinely treated. Aneurysm treatment was really for those patients who had suffered a subarachnoid hemorrhage. So the beginning of the study of the natural history of unruptured aneurysms with this paper and the subsequent efforts of others was a huge leap forward in cerebrovascular neurosurgery.
Absolutely, and kind of dovetailing into that, the Finnish group published another landmark paper in 1993, and in this paper, they followed aneurysms for many years. The median follow-up time was 14 years, but in their country, there was a institutional and national policy not to treat unruptured aneurysms prior to 1959, just as Chris had mentioned. So in this study, they had 142 patients with 181 aneurysms. During close to 2,000 patient years, 27 patients experienced rupture. That came to an annual rate of about 1.4% per year. That was the number that was taught to me during my training, that the risk of an aneurysm rupturing spontaneously is about 1.5%. Cumulative risk about 32% at 30 years. So what they found, there wasn't a distinct aneurysm size cutoff in terms of which aneurysms were risky, but they did note a linear relationship between aneurysm size and rupture. Now, because all of these patients were followed rather than had any type of treatment, there's no selection bias for treatment. Every aneurysm, again, that's identified is just followed, and they had a phenomenal follow-up for this study. But the important thing to note, though, is if you look specifically at their 142 patients, the majority of these patients were diagnosed because they had a prior subarachnoid hemorrhage. About 131 of them, these unruptured aneurysms were identified because they had some type of, or 6 of them were identified because of massive. As we saw from the earlier Weaver study, and generally speaking, you need a larger aneurysm before you're going to experience any symptomatology from it from a cranial neuropathy standpoint. So that actually leaves just a handful of patients who were truly incidental aneurysms, no subarachnoid hemorrhage or massive. But so if you look at this study, this is also, even though there isn't a selection bias for treatment, there's clearly a selection bias in terms of how they identify these aneurysms. Patients, again, will undergo catheter angiography to identify it, and the bar for that, for a that study is much higher than it is in current days where we can do non-invasive imaging at the drop of a hat. Following this, this was a very, very big paper, the International Study of Unruptured Intracranial Aneurysm Investigated, initially published in 1998. This is a study that during my residency training, this had been published just before I started residency, and we were critically analyzing this study ad nauseum at the time. And this was a retrospective study to determine the rupture risk in over 1,400 patients with 1,900 aneurysms. So the patients were grouped into 2 cohorts, one with a prior history of subarachnoid hemorrhage, which was group 2 patients, and half without a prior history of subarachnoid. Additionally, about 1,100 patients who underwent treatment were followed prospectively to determine treatment-related morbidity and mortality. Based on their retrospective analysis, the rupture risk for group 1 patients was less than 0.05% per year for aneurysms smaller than 10 millimeters. Group 2 patients had a higher rupture risk, about 10-fold higher, but still much lower than what was previously reported at 0.5% per year for aneurysms smaller than 10 millimeters. Overall, the rupture rates for all aneurysms in their study was less than 1%. And this caused a significant amount of debate within the neurosurgical community because the data that we had earlier was pointing toward a much lower or a much higher rupture risk. The treatment risks were 17% and 15% for group 1 patients at 30 days and 1 year, and 13.6% and 13.1% for group 2 patients. So additionally, what they found is not only were aneurysms much less likely to rupture than we believe, but our treatments were also more dangerous than we've been reporting. So based upon these findings, in combination with the rupture risk and the treatment morbidity and mortality, the investigators posited that treatment risk for aneurysms less than 10 millimeters likely did not outweigh the benefit in terms of preventing future rupture. With this study, though, there was significant concerns for pre-selection in the retrospective series. Aneurysms were followed based on their data if they had not been previously treated. If the treating physician at the time felt that this was a low-risk aneurysm, then you would obviously just observe it, but if it was a high-risk aneurysm, it would be treated and it would never enter into the data set to determine the natural history of all cerebral aneurysms. This resulted in significant underrepresentation of larger aneurysms, especially in the patient population with higher subarachnoid hemorrhage, and overrepresentation of safer aneurysms, small cavernous ICA aneurysms, which we generally don't treat. In essence, if you look at this study, this is an excellent natural history study on aneurysms which a neurosurgeon or a neurointerventionalist would opt to follow rather than treat. So this is not what you would consider representative of the true natural history of cerebral aneurysm, but of a highly selected population. This was followed several years later by basically what became known as ISSUA 2, and this was published in 2003. And this involved a prospective assessment of unruptured aneurysms of 4,000 patients over a 7-year period. This was a 3-arm study. There was an observation arm in which they attempted to redefine the natural history, whereas the previous ISSUA study was a retrospective evaluation of the natural history. So this, they proceeded with the prospective, but as well as the treatment outcomes for both surgical and endovascular treatment. So 1,600 patients were included in the natural history arms, and just as in the prior ISSUA study, they were grouped based upon the prior history of subarachnoid hemorrhage or not. And they determined 5-year rupture risk based on the location of the aneurysm, either the anterior or posterior circulation, as well as the size of the aneurysm. In their entire series, 61 patients, or 3%, experienced rupture. They did demonstrate a higher 5-year rupture risk than in the previous ISSUA study. However, aneurysms less than 7 millimeters in size in the anterior circulation, patients who had not had a ruptured aneurysm previously, still had a very low rate of rupture of 0.1% per posterior communicating artery aneurysms, interestingly, were included in the posterior circulation. As far as the treatment outcome, surgical complication rates at 1 year was 12% for group 1 and 10% for group 2. Endovascular complication rates were 9.8% and 7.1%, same groups. Although the endovascular patients were older, generally had larger aneurysms, also had more posterior circulation. Again, the risk of aneurysm rupture was similar to the complication rates of treatment, and that did narrow the margin somewhat compared to ISSUA 1, but there were still significant concerns based upon whether or not this was identifying the true natural history, because the selection bias for treatment still existed. Observation versus treatment was predetermined by the treating physician. So as far as whether or not this can be considered a true representation of the natural history of all aneurysms is very debatable. And as we've seen, this selection bias exists in almost all of these natural history studies. There's been multiple other studies published, especially in Japan, that have looked into this question as well, but they still suffer from the selection bias. What we're determining is the natural history of aneurysms we have not pre-selected. So in our first case example, that posterior communicating artery aneurysm, if this were enrolled in a similar type study, would not be included in the natural history cohort, because I would have selected that one for treatment, and we would have instead followed the natural history of ICA terminus aneurysm, which measured about 2 millimeters. So based upon this heavy pre-selection of aneurysms, can you apply the natural history data that we have in the literature to that posterior communicating artery aneurysm, which looks significantly different than the ICA terminus. That is a fundamental problem that we have that has not been answered in a rigorous scientific manner. And as we know from the Finnish group, even though all aneurysms were observed rather than treated, and that represents probably the best natural history data, you do have to understand that the vast majority of those aneurysms were found in patients who had a prior subarachnoid. So in essence, these were group 2 patients versus what you would consider group 1, the true incidental aneurysm without a prior history. Now, people have attempted to find the natural history of all aneurysms. This was a study that Jean Raymond out of Montreal had started, and this was a prospective randomized trial of endovascular treatment versus natural history. And in this study, the goal was to randomize all aneurysms, and it's basically a 50-50 coin flip, observation versus treatment, and eliminate the selection bias for treatment that exists in the vast majority of the natural history studies. The plan was to recruit 2,000 patients in 3 to 4 years from 50 international centers. They received funding from the NIH and its equivalents in other countries. However, after 3 years, this trial was terminated, and largely due to the fact that they could not get patients enrolled. Either the treating physician felt ethically, apologize, I'm not advancing. Here you go. Are not, the treating physician does not feel ethically comfortable randomizing certain types of aneurysm. Maybe you have a 12-millimeter basilar tip aneurysm in a young woman. Would you include that patient in a randomization trial where one of the treatment arms is observation? The other issue is that patients oftentimes don't want to be randomized to treatment versus observation. You can have more success in terms of randomizing which type of treatment option versus whether or not you're going to treat. And when they did their analysis of the data, they found that it would have taken multiple decades to recruit the 2,000 patients. So after 3 years, or 2.5 years, this study was terminated prematurely. So why do we treat aneurysms? Largely to eliminate the rupture risk. We need to exclude the aneurysm from the circulation, keep the blood flow out of the aneurysm, and hopefully that's going to prevent the aneurysm having a bleeding event in the future. Two options are surgical, either clipping, clip wrapping, or you can also do occlusion with or without bypass, depending on the circulation. There's multiple endovascular techniques as well. Coil embolization is what started previously. You can use adjunctive techniques with stents or balloons. Flow diversion, which has come out in the last decade, has really pioneered the treatment for cerebral aneurysms, and now we're even testing intrasaccular occlusion devices, which we won't really go into. So who should we treat? Patients with aneurysms that are likely to rupture during their lifetime. Those are the individuals that are going to benefit. So in my clinic, I do get quite a bit of referrals for 80-year-olds who have an incidental aneurysm. Very easy discussion, but as we know, we're trying to eliminate a lifetime rupture risk, and the lifetime expectancy of an 80-year-old is much different than a 60-year-old or a 30-year-old. And then the point at which aneurysm treatment is beneficial is where that rupture risk curve crosses what the treatment risk curve is. And once you get to that stage, then you can, in my opinion, justify when an aneurysm should be treated. How do we identify these patients? There have been multiple studies that have been published that have attempted to identify patients who are at highest risk for aneurysm rupture or requiring aneurysm treatment. Now, Chris, do you use any of these scales that have been published?
I tend not to because, like many of the other studies, there's not a sort of one-size-fits-all scale for patients. I mean, for example, if you think about phases, which I'm sure you're going to talk about here in a little bit more detail, in a patient with no other risk factors who has a 9 millimeter ICA aneurysm, the phases score is 3, versus a same patient with no other risk factors who has a 2 millimeter econ aneurysm, their phases score is 4. So that doesn't really make it easier, at least in my practice, to identify those patients who I think are at highest risk of rupture. Because when you think about the recommendation based on phases, a score of equal to or less than 3, generally the recommendation is to not treat. But again, in a very common clinical scenario that I just described, those scores don't necessarily make common sense. So we get much more into the weeds of the art of treating aneurysms and making recommendations based on experience in the literature versus the pure science, because unfortunately the data we have is somewhat inexact.
Yeah. So this is exactly where we are in terms of looking at. There's multiple scales that have been proposed. Phases, UIATS are some of the more common ones. Intuition, I think a lot of us still rely on that. I know I do. I don't routinely use phases with UIATS either in terms of making the final determination as to how to keep treatment. And of course, there's you just treat everyone philosophy as well. But looking at the phases score.
Can I interrupt for just 1 second?
Yeah.
I think there's been a couple of questions about audio quality. I can hear Dr. Park very clearly in Florida. Is everyone else out there hearing us okay? If a few of you could respond in the Q&A. Okay, good. I hear all good. If you're having trouble hearing us, please use the Q&A to let us know that you're not. But I'm hearing them fine, and it sounds like most of you are as well. So, okay, excellent. Thank you.
So the phases score was developed to help as a screening tool for predicting the risk of rupture of intracranial aneurysm. And it's been studied extensively to determine whether or not it has validity in terms of the medical practice. I think it can serve as a screening tool to kind of guide your management, but as we know, it's not perfectly applicable to all patients, and there are other instances too where your recommendation may differ from what the recommendation based on the scoring. The other thing with the phases score, they did look at the natural history data to determine their rupture risk. And as we've seen, and there have also been extensive editorials about this, when you're taking flawed data to determine what your rupture risk is, how valid is that ultimate scale if your prospective cohort studies suffer from significant selection bias. To overcome that, there was another large enterprise to determine how we can best manage and how we can make our best recommendation. and this was published 5 years ago in the journal Neurology. It's called the Unruptured Intracranial Aneurysm Treatment Score. So unlike phases, which relied on the natural history of the published natural history data, this was determined very differently. In this study, they went through what's called the Delphi consensus model, and they had an extensive list of the eminent cerebrovascular neurosurgeons and radiologists and neurologists who got together and using the Delphi consensus model tried to figure out and come to a consensus as to what are the factors which make us worry about aneurysms and at what point would we recognize aneurysm treatment. And with this, they came up with a scoring system as well, and they said, well, you have based upon the score you can have either recommended treatment, recommended observation, or what's called the gray zone, when either treatment options are reasonable. We actually looked at this when I was at Utah and determined that, in essence, looking at a real-world practice in a retrospective manner and applying the UIATS score to it, we actually found that this treatment score was more aggressive than what 4 or 5 cerebrovascular neurosurgeons who had trained at different institutions were finding. So even though that was, again, a larger retrospective data, I think it does demonstrate that these scores are not the main determinant that a lot of us are using to make our decision. I think we do consider a lot of the data or a lot of the factors that were included in both the phases and the UIHTS, but a lot of us also still are relying heavily on intuition, how we were trained, and what our beliefs are. Chris, have you seen the UIHTS score?
I don't routinely use that.
No. Yeah, again, and there are other scales as well. The Buffalo group has published one using computational fluid dynamics as well to help determine which aneurysm might be at higher risk of rupture. And obviously, we're still trying to gather data to help determine this. Unfortunately, again, all of it is retrospective in nature, as the team trial demonstrated. We're just not ethically able to or practically able to come up to a true determination of the natural history. So, during my training, I was taught that if an aneurysm isn't 100% secure, it is still at risk, and the goal of all aneurysm treatment should be 100% occlusion, which again is the best goal. The question is, at what risk do you pursue that? Basically, the question, what we want to know is how much of that aneurysm needs to be secured in order to reduce the risk of rupture. Are dog ears acceptable, right, when you're clipping an aneurysm? If you're coiling an aneurysm, how much residual filling is acceptable? And if you need to do something that increases the complexity of the aneurysm treatment, is that a worthwhile endeavor if 95% occlusion of the aneurysm reduces the rupture risk nearly as well as 100% occlusion? What we do know as far as looking at the ruptured aneurysm trial, and the ISAT trial, again, a very pivotal study in world of cerebrovascular care, the re-rupture rates are exceedingly low with treatment of ruptured aneurysms. Again, we're making a generalization that this would somewhat follow for unruptured aneurysms. But the rebleeding rates at 1 year for the endovascular arm, 2.4%, whereas in the surgical arm it was 1%. So again, this is a ruptured aneurysm cohort which we believe has a higher risk of subsequent rupture than the unruptured aneurysm. But we do have data, again, for this in a very good randomized prospective trial. Now, since rupture rates are very low for either treatment arm. And the question is, in terms of either treatment arm, what data do we have in terms of recurrences and ruptures? Dr. Lawton published this series several years ago, and this is actually pretty novel in the sense that he was able to follow his microsurgical patients with aneurysm clippings with catheter angiography. The follow-up that is recommended for aneurysm treatment in the surgical literature is highly varied. And there are individuals who will spot check with non-invasive imaging. There are individuals who also believe that a clipped aneurysm will never re-rupture, and I'll follow it again, maybe after the short-term period. In this series of 240 patients with 380 aneurysms, we did identify about 4.6% of his post-op catheter angiograms demonstrated residual, but part of those residuals were planned due to clip positioning and what the anatomy allowed, and just only a small percentage of those were not previously unknown residuals at the time of surgery. Those patients who did have a residual aneurysm, about 12.5% demonstrated regrowth at a rate of about 2.1% per year. Of the ones that were 100% occluded, only 1.5% demonstrated recurrence, which was about 0.26% per year. So even with the surgical series, there is a need for continued follow-up. And this is not speaking to whether or not these aneurysms will rupture, but if you think logically, if the recurrence of an aneurysm or the residual part of an aneurysm treatment that you would be worried about in terms of aneurysm rupture. For endovascular treatment, the rupture rates are significantly higher. With primary coil embolization, historically, you can find series up to 40% of recurrences. I think with some modern devices and techniques, we have lowered that considerably. Even with flow diversion, there isn't any published reports of recurrences, although there are well-known issues of residual aneurysm. So if you have a recurrence, you have several options. Endovascular, I think, in this day and age, tends to be the primary means of treating recurrences. I'm not a big fan of reoperating after an aneurysm. I don't know, Dr. Fox, if you practice that often or at all?
Can you say the last part? I lost you for about 5 seconds.
Oh, as far as recurrences, have you had any instances where you needed to treat those surgically rather than endovascularly?
Like you mentioned, I try to avoid repeat microsurgical clipping just because of the scar and the unclear dissection planes. So I think this is one area where flow diversion has made a huge difference, because often for a recurrent aneurysm, either that's been clipped or endovascularly treated, flow diversion can be a really powerful tool for this. And I think, as the technology has expanded, and particularly with intrasaccular devices such as the web device, how much of the aneurysm has to be obliterated is becoming more of a moving target. Like Dr. Park, when I was trained, it was drilled into me that if the aneurysm is not completely occluded, the rupture risk remains. And it's, the goal of treating an aneurysm is to completely obliterate it. If you're not going to do that, then you shouldn't even treat it, essentially was the teaching at the time. And that's changing a little bit. Just one comment on Dr. Lawton's paper, which is a great series. In spite of all of our work on aneurysms, there's not that much out there in the literature about how long these patients should be followed and who deserves closer follow-up. I think it's important to note, if you have a residual, whether it's intentional or unintentional, it's very important to follow that. That's been borne out in a recent study we did at the University of Florida, looking at a few hundred patients. And I think it's important that everybody who's interested in this field think about reporting their long-term data, so we can come up as a group as a specialty with a little bit more unified and uniform procedures for following these patients. And that also includes with what imaging modality.
No, absolutely. I think there's still a lot of data that needs to be gathered. And hopefully, especially with this generation of residents coming up, as we understand more and more about the science of data collection, we'll get some hard answers. This is a representative case here. This is something that we see rather frequently. This was a 70-year-old woman who had a just under 8 millimeter ACA aneurysm. Initial treatment was with coiling, with stent-assisted coiling, which resulted in a Ramon-3 occlusion, which, for those of you who are not familiar with endovascular grading, Ramon 1 is complete occlusion, Ramon 2 is residual filling at the neck, Ramon 3 is anywhere within the dome. The 6-month follow-up angiogram, and this was the initial aneurysm, this was the initial treatment. The 6-month follow-up angiogram demonstrated a significant there, and she underwent subsequent recoiling, and you have the assistant here. You can see the stent markers, and this is the new coil pack. On her follow-up at a couple of years later, you can see that she's had another recurrence of this aneurysm. She actually was identified during our evaluation, and this is the point at which I inherited her, and you can see on the another view of this recurrence. It's fairly sizable. It's in a different portion of where the previous recurrence was, here in the lower portion of the aneurysm. Initial plans, as Dr. Fox had mentioned, flow diversion is a viable option in these instances. However, during the workup, because you're going to put somebody on dual antiplatelet agents, she was found to be thrombocytopenic, and then noted to have bleeding for rectum, and we actually diagnosed a colon cancer. She ultimately underwent treatment for that and was in remission, went through chemotherapy, and at a later stage, just because of the concerns for her any future or acute surgical needs, we elected just to proceed with coil embolization again. At this stage, we've got a Ramon 2. A little bit of contrast in here. Maybe not the ideal treatment if you look at specifically the aneurysm, but in her instance, I think this was the best option. With repeat coil embolization, we do have literature looking at what the risks are, and it ends up being safer than the primary embolization in terms of complications. The thought process is that the coils that are there are actually lining the dome of the aneurysm and are protecting the wall of the aneurysm from your manipulation of catheter, wires, coils. If there's a stent there, it's well endothelialized at that stage, and it gives you a nice secure platform and helps protect the current vessel. And you also have generally smaller volumes embolized compared with the original aneurysm. Some of the challenges that you see, again, visualization becomes an issue because you have a lot more metallic material in there. You can have challenges with the access to the aneurysm and might require adjunct technique, especially if you do have a stent. The one thing we do with pipeline embolization and flow diversion, for some reason the presence of a prior stent actually leads to less efficacy of the flow diverter itself. And this was a patient who 20 years previously had a ruptured posterior communicating artery aneurysm, underwent clip ligation at that stage, and then 20 years hence has significant recurrence where you can see the clip is actually at the dome of the aneurysm. So the aneurysm grew in from the neck portion of the parent artery, and as it grew, it pushed the clip further away from the parent vessel. At the time, the management option was a reclipping, but ended up with significant visualization problems, just because of the size of the aneurysm. Some of the adhesion scarring that had occurred following the initial rupture and treatment. And it wasn't an ideal aneurysm. They basically bifurcated this aneurysm. There are now two lobes to this aneurysm, here and here, with clips coming across. Then, because of that significant residual, the patient underwent coil embolization, primary coil embolization, given the setting. And you can see here's the coil mass down here and a coil mass here, with residual filling within the neck aneurysm. This is a point that the patient presented to me, and follow-up. You can see the visualization problem. Got multiple surgical clips and several coil masses. Eventually, we were able to find a working angle to demonstrate the recurrence of the lower lobe as well as superior lobe of that angle. And in this instance, able to place a flow diversion. You won't see the flow diversion, but this is the contrast space that you see with flow diversion. Both of those lobes, these aneurysms. So with flow diversion, the advantage is you're not manipulating the dome, you're staying within the parent vessel, and you are reinforcing the normal vessel rather than proceeding with placement of coils within the angle. Recurrence, again, we have not had a published report of a recurrence, but we do have multiple examples where lengthy follow-up. Visualization, as we said, in previously treated aneurysms is a significant issue, and I think we sometimes minimize the risk of the medication required to allow you to see flow diversion. And you really do have to be very careful if the patient has any bleeding diaphysis or is a hyper-responder to some of your anti-platelet agents. What happens if there's a residual aneurysm after flow diversion? Your options are limited. Endovascular does not work particularly. Coil embolization is not possible. You cannot stand the times of the flow diverting device with catheters or microwires. So there's no way to perform coil embolization after a pipeline has been placed. Your only endovascular option for all intents and purposes is to place more flow diversion. With surgery, clipping is, again, always an option. That can be complicated, again, by the antiplatelet regimen. You have to essentially time your intervention very carefully, especially not something that you would want to do in the acute period when they're on dual antiplatelet agents. Maybe later on, when the device is ilealized and they're on monotherapy with aspirin, find a window to proceed with surgical treatment, and also parent artery occlusion with bypass.
Matt, just to interrupt for a second, we have a couple of questions, both good questions. The first one is, in what situations would you consider a combined endovascular and microsurgical approach? Is a combined approach commonly employed or reserved for more complex aneurysms?
Yeah, that is a very good question. As far as in my practice, I have not needed to combine. I can see instances where the endovascular can help with parent artery occlusion, whereas if you are doing a bypass, you can temporarily occlude with a balloon during the microsurgical part, so that you don't have to worry about constant control as much. I don't know. Have you had any instances, Chris?
I have not, actually. I usually make a decision one way or the other, endovascular or surgical, and then go with that. So I haven't come across that in my own practice to this point, but it's a good question. I think by definition, if you're combining approaches, it's probably going to be a complex situation. I do know that, this is not an aneurysm question, but I know that Dr. Park has some experience because of cases we've discussed in the past with combined open and endovascular approaches for vascular malformations. He's published on that in a very eloquent way, but that's a topic for another time. The second question is carotid occlusion, is it a viable option for multiple recurrences? That is, if the patient passes the BTO.
I think it is always an option. It tends to be one of my lower on scale as far as coronary occlusion. I try and do reconstructive techniques as much as possible for deconstructive. I think though for larger aneurysms of the skull base, like large cavernous or ICA aneurysms, that is something you do have to consider if there have been multiple recurrences. But even with recurrences, a lot of times you still have other options, just like that ACA aneurysm coiling case. Sometimes it just takes multiple coiling attempts to get there, and after the third procedure for her, after about 2.5 years, at least we have not seen the early recurrences that she had treated. I think coronary artery occlusion, again, either endovascularly or surgically, if they pass a balloon test occlusion, is an option. You do have to remember that there are the balloon test occlusion, depending on how you do it, or no matter which technique you use or which imaging study, whether you're just doing it clinically or xenon or perfusion studies in conjunction with the balloon test occlusion, there are patients who will pass it that will ultimately end up having strokes. So there's definitely false positive rates associated with that study.
Yeah, that's a good thing to keep in mind. The BTO is not, 100% sensitive. So in my practice, I have not used a BTO for recurrence. In the last 5 years, I can think of, I have not used a apparent vessel occlusion, I should say, for an occurrence, a recurrence. But in the past 5 years, I can think of one case that we treated with carotid artery sacrifice, and it was a patient with a giant partially thrombosed ICA terminus aneurysm, who was older and had significant medical comorbidities. So the options were basically a bypass procedure or carotid occlusion, because I was unable, given the size of the aneurysm and some stenosis at the proximal portion of the MCA, to get a catheter through there to flow divert. So we did a BTO and sacrificed the carotid, and the patient ended up doing all right. But that's a fairly rare occurrence, I think, in today's day and age with multiple techniques.
Yeah, I think nowadays when we are looking at that as an option, it's like the case that Chris had mentioned. We kind of know going into it that that's what we're going to do. And our large and giant aneurysm skull base for coronary artery occlusion. Usually, again, as a bailout, if we can't proceed with flow diversion. But again, there's going to be many instances where what we originally planned does not work. Again, well, just in the interest of time, we can kind of go through quickly. There are recurrence rates after pipeline embolization, or retreatment rates after pipeline embolization, but they tend to be pretty low and in line with the coil embolization data in terms of retreatment rates of, generally speaking, 5 to 10% based on the published literature. In some instances, this was a young man who had this large fusiform MCA aneurysm and was treated several years ago, about 12 years ago, with bypass and occlusion. And the short interval follow-up looked pretty darn good. And this was the aneurysm here. At that stage, there was no endovascular option. The patient did very well after surgery. However, they lost follow-up for several years, and then eventually came back, and this was the recurrence of the aneurysm. This is the bypass and the MCA, and you can see that this is now a very large fusiform aneurysm, just distal to the lip, with a clearly abnormal middle cerebral artery branch vessel. Now, I don't want to put Dr. Fox, or I hate to put Dr. Fox on the spotlight here, but what options do you think you have based on these limited images.
I mean, that's a very tough aneurysm. To be honest, I was answering a question from one of the respondents, so I missed the very beginning. So it's a patient who had been clipped and then recurred and now has this fusiform
he had a
vascular aneurysm.
Yeah, he had a large MCA aneurysm, and it was treated with current artery occlusion and bypass 12 years ago.
Mm-hmm.
And then at the initial short-term bypass site looks good. The aneurysm is occluded. Then 3 years later, this is what his angiogram.
Yeah, I mean that's a tough problem when you when you sort of gone to one of the most fail-safe options for preventing recurrence, that is bypass, and then you have a recurrence. To me, just looking at these few cuts, I'm not sure that's something that could be clip reconstructed, at least in my hands, and I would have significant concerns about attempting that. So for me, I think the options are to try to figure out if I could do something vascularly there versus, I don't know if there had been any previous imaging, but the other thing with the fusiform component is just continuing to follow that for a while and see if it changes.
Yeah, when I saw him, I had the benefit of about 6 years of close interval follow-up after his initial period where this fortunately has remained stable over the last 7 years. I've elected to continue to watch it, although, again, as in all instances, I had a very detailed discussion with him. So what we're up against. The flow diversion was not an option just because the diameter of the vessels are way too large. We do not have devices that are that big. And there wasn't really an aneurysm coiled. The bypass had already been performed, and his targets for bypass were exceedingly small in terms of then you would be doing 2 or 3 branches because you'd be trying to bypass in 4 segments. Require multiple bypass. After a lengthy discussion, the patient selected watching.
Yeah, I think these larger fusiform aneurysms are very difficult to treat, regardless of the approach or the location. I mean, it would be a much different presentation than this case, but for large posterior circulation fusiform aneurysms, these are still something that are very difficult to treat with any modality, something that's been described is the double barrel flow diversion technique, because the current flow diverters, at least they're widely available, that can only expand to be so large. But I think when you're faced with these sort of one-off aneurysms that you only see on very rare occasions, it requires a lot of creativity to treat. And I think another point to make to particularly the trainees who are listening, you should never feel like you're treating these things on your own. This is why it's important to have good relationships with your colleagues, both at your institution and elsewhere. Dr. Park and I frequently discuss cases among a group of our friends who do cerebrovascular all over the country. So these difficult aneurysms, it's don't feel like you have to be the buck doesn't always have to stop with you at the first time you see the patient. There's nothing wrong with asking others' opinions.
Oh, absolutely. I think I even to this day, until I retire, I will still be learning and relying on others' needs that I value. And again, sometimes the answer is observation. Not get too aggressive. First, do no harm. And obviously, this individual, having had a bypass previously and a patent bypass, developing multiple fusiform aneurysms along the branches, this is clearly a patient extremely high risk. Again, I conferred with multiple individuals what our options are with. Overall, most people were forward observation, close interval observation, proceeding with. But and in conclusion, again, as we said, we talk about the natural history of cerebral aneurysms, but it's largely based upon data sets which have inherent issues and biases. So if you try and determine what the true history of unruptured aneurysm, the answer is we don't know. The issue of papers were also heavily selected, and even though we have randomized prospective data, it may not mirror what is the true natural history. Treatment options are varied, and they are changing constantly. In the field of endovascular neurosurgery, the technological advances seem to be happening on a weekly basis. But you have to consider all options. If you're if you have strength in one skill set, then that's fantastic. You probably do an excellent job in it. But as Chris had mentioned, don't be. There's nothing wrong with asking for help. Nothing wrong with looking at something and saying, you know what, this is not in the patient's best interest for me to treat. There's absolutely nothing wrong with that. It can be the correct answer for that patient and for you. Thank you very much. I think there's any other questions we're happy to entertain.
Excellent thought, man. This is a nuanced and complex discussion. I think you hit the high points excellently, and oftentimes there's more than one right answer. So I would just encourage everyone to keep that in mind. And this is a team sport, so don't be afraid to get your colleagues involved, particularly as treatment and devices become increasingly complex. So what questions does everyone have? Please feel free to ask anything. I have a question for you, then. What is your usual follow-up for a patient who has, let's say, a middle-aged patient who's relatively healthy, who has a 4-millimeter aneurysm in the anterior circulation that you decided not to treat? What do you typically do to follow that patient?
I do non-invasive imaging. I generally prefer MRAs just to decrease any radiation exposure, even though the CTAs nowadays have very, very low doses. But as an endovascular specialist as well, I'm particularly attuned to radiation exposure. So I do MRA follow-ups yearly for the first couple of years, and then after that, I'll do every 2 years, and then 5, 10 follow along over time. Because again, we're trying to document growth of an aneurysm, but we also have to be cognizant of efficient use of our limited medical resources. What do you do for incidental aneurysm?
I do something similar where I'll often, just because of the very high quality of the CTA, for my initial non-invasive imaging, I usually use a CTA. If there's any question with a new patient where we need to document more carefully the characteristics of the aneurysm, then we'll do a diagnostic angiogram. But then I will typically try to transition over at some point to MRA to follow the patient without the use of radiation. And what I've been doing is following these patients sort of at doubling times, so a year, then 2 years, 4 years, et cetera. And often what I'll do, because many patients want to get their imaging closer to home and the quality may not be the same, I'll have them get their initial follow-up. They'll get a CTA at our institution and an MRA closer to home, so I can compare that early on and know what the differences are between the modalities. And then as long as I feel comfortable with the quality of the MRA and then getting it closer to home, they can do that and mail it. My overall goal is like you said, to be able to document that the aneurysm is not changing, but do it in a way that's responsible and efficient in terms of resources and protecting the patient from a lot of radiation. We have another question as well. What are your thoughts on the web device, Dr. Park?
I have used it several times, and both of those aneurysms they were definitely ones where one was extremely high risk and really had no other endovascular treatment options, and she unfortunately was also very high surgically. Healthiest person with a very wide neck. You know, in the short-term interval on subsequent scans, things look good. You do have to reframe how you look at follow-up studies. Again, they've come up with their own definition of what a recurrence is. And the jury is out, though, on what the long-term efficacy is. It is such a novel device. It does make sense. But we have had multiple devices in the past that were supposed to fix everything. The Onyx 500 was one type solution to high-risk aneurysm that turned out to be much less of a leap forward as we had suspected, and we are no longer using liquid embolic. Hopefully, the data will prove that web devices and these intrasaccular devices will be as effective as a pipeline has demonstrated.
Which was very prevalent when we were doing our fellowship. It's nearly gone away now. We have to critically evaluate all these new devices to make sure that they're achieving the results that we want. But I do think that intrasaccular flow diversion does have tremendous promise. We have another question, too, and it is, if you follow patients with untreatable lesions, at what point would you intervene? And if you're not going to intervene, then why follow?
That's an excellent question. Well, again, I think part of it is that, what I learned training, years ago to what I do now is very different. Just because I don't have an option now doesn't mean I won't have an option in the future. And with a busy clinical practice, you can easily fall through the cracks if you don't keep tabs and have routine schedule follow-ups where you know that's in the system. And also, for me, when I elect to do any type of procedure, you have to say, what is the risk of not doing something versus what is the risk of doing something? And at certain points, that's a moving target. Again, if technology advances, the risk of the treatment might go down. But if the aneurysm grows, the risk of doing nothing might go up. And at that stage, then if you think of a scale and you're putting stones into the treatment basket, stones in the observation basket, that scale can tip in the other direction. So I think it is important if you find that this becomes much more worrisome, as the case that we had shown, I demonstrated with the MCA aneurysm. It's been stable over 7 years. So I'm not, I had the luxury of not having to make that decision early on, and that as I, picked him up and follow up, say, well, it's been stable for 7 years. Has anything changed to warrant a change in our management approach? That answer is no. If it starts to grow, obviously, then the risk increases. Then you might have to reconsider the more risky options that at the time that you made your initial decision aren't a viable option.
Yeah, I can think of a recent patient in particular, not so much that the aneurysm changed, but that her overall physical health change. This is a plug for spine surgery since I also do that. But I saw a patient with an aneurysm who I generally would have recommended treatment to, but she had such severe back pain she was unwilling to do anything that would keep her in the hospital because she wouldn't be able to manage her back pain. So she actually ended up having spine surgery, came back to see me for her follow-up imaging a year later, was like a completely different person, and then wanted to have her aneurysm treatment. So I think there are factors that are specific to the aneurysm and then factors that are specific to the patient that may change over time. So one reason to keep following patients. There's another question about is there a concern that trainees are being taught more endovascular and down the line less will be comfortable converting to open if needed? I think, that's certainly a concern. There's a move towards endovascular treatment, I think, for many reasons. There's less open cerebrovascular surgery that is occurring, and that means there's less opportunity for trainees to be exposed to this. There's certainly still a number of neurosurgical, microsurgical masters out there doing lots of clipping, but that number has become less and less over time. So there are implications for that going forward, and particularly if you're interested in doing open and endovascular treatment, there are implications for trainees as to where you might want to consider doing your fellowship.
Yeah, absolutely. I think a perfect, or not a perfect, but a very close issue or related situation happened in cardiothoracic surgery, and where the interventional cardiologists have now dominated the field. I think fortunately for us as neurosurgeons, we were on the forefront and we did not get relegated to the sideline. Our leadership in our community was very, very adamant about the need for neurosurgeons to have a very large role, appropriate role in treatment. But that is a question we struggle with at our institution, as in a lot of other institutions. The senior leadership in neurosurgery is, they've reflected this new treatment paradigm shift by the case log requirement. Historically, there was X number of aneurysms to treat open microsurgically. That has now shifted, and again, that's with the very sizable change in treatment strategy with the new technology.
We have, we're getting a little bit long on time, but since we have some excellent questions still coming in, I think we can probably try to answer these last two. One is about what's your opinion on MCA aneurysms? Do you prefer endovascular or clipping, or what's the characteristics that help shape your decision?
Personally, I would, assuming all things equal, I still tend to look at those for surgical clipping. Those are probably the ones that I look at closest for surgical clipping. My residents may argue with me that that's not reality, but at least in my mind, those are the ones that I would look at for clipping in an elective fashion. But even in a ruptured fashion, I do tend to examine those for microsurgery. What about you, Chris?
Yeah, I definitely tend to think of MCA aneurysms in a little bit more of an open microsurgical clipping fashion rather than endovascular treatment. That being said, I think most patients I see would prefer a minimally invasive endovascular approach than clipping. So, I have the discussion with each patient about here are the options. Some aneurysms are amenable to either option, and other aneurysms are amenable to one or the other. So I basically just give them my honest opinion about what I think is best in my hands. I have had some MCA aneurysms where I recommend clipping, but the patient said if there's any option to treat this endovascularly, then please do that. So, I think when you have the option to do both, one nice thing is you don't feel like you have to force it one way or the other. So, if you're trying to treat something endovascular because the patient feels very strongly that they want that, you always have the option of backing out if you're doing the procedure and you can't safely accomplish your goal. There's nothing wrong with bailing on endovascular treatment and telling them, hey, we need to clip this. So I think the more options you have, the less, everything looks like a nail when you just have a hammer. So I just try to keep an open mind about what the best options are, discuss them with the patients, give them my honest opinion, and go from there. That gets into our last question also about, given the data on rupture risk is controversial and patient-specific, how do you counsel the patients when considering observation? I just spoke a little bit about that, and Nen has addressed that a bit as well. I think, for me, the main message I try to convey to patients is that if I think the risk of treatment is higher than the risk of observation, then I can't, in good conscience, recommend that to the patient. So for me, it's all about risk-benefit, and I try to use the data as much as possible, explaining what we know, much of which has been presented today, and then also discuss my experience and come up with a logical recommendation for patients. I also really try to involve the patient in their own decision-making so they don't feel like they're being pushed in one direction or the other, because I think one way, particularly in cerebrovascular, to mitigate less than ideal outcomes, which, given the nature of cerebrovascular, no one's going to have a 100% success rate. I think one way to help with that is to really partner with your patients and make sure they're well informed and they really know what the risks and benefits are. The informed consent process for these patients is extremely important.
Yeah, I have to echo what Chris said. That is, I think historically physicians have been the ones to dictate treatment, but nowadays it is a true team approach. There are still those patients, and I will still see them, that will say, you tell me what to do. In that instance, they are inviting for recommendations to follow. In other instances, in those gray zones, that's always the toughest. Well, what are you more comfortable with? You have an overall low risk of observation, and you have an overall low risk of a treatment, and those risks are probably the same over time. With treatment, that risk is immediate. At the time of treatment is generally when we have problems. Whereas with observation, that's a lifelong risk, and one that it can happen, in inopportune moments. You can't predict it. So it really, building that relationship with the patient first. They need to understand. They have to really feel that you have their best interest. Without that elemental step, I think you're going to run into issues throughout their care.
Great. Well, I think we've answered the questions that have come through, and we very much appreciate everyone's attention and joining us today for this CMS Virtual Visiting Professor program. Again, please keep in mind that this is just the early stage of this program. CMS is dedicated to offering educational content all the time, and particularly now with the way things are with COVID. So please stay tuned for further events. I think Dr. Dan Resnick will be on Tuesday discussing his experience in spine surgery. So lots of great opportunities to stay involved and keep learning even when you may not be at the hospital.
Thank you, Dr. Park. Thank you, Dr. Fox. Have a great day, everyone.